All right, so thank you so much for coming to this presentation. I'm very excited to be able to speak to you all. And also thank you so much, Liam, for putting this together. I'm going to start with some basics about myself and about autism and dispelling some common stereotypes that are often misunderstandings, but can have real consequences to the quality of care for autistic patients and clients. Then we'll look at what this all means when working with autistic clients with a variety of tips and tricks, both on effective communication and some common comorbidities that may prove handy to know about, and some other helpful information. We're going to cover a lot, but this slideshow with all of my speaker notes and links, along with a Google Doc with all of the individual links I'm going to be recommending folks check for more information, is going to be posted in the chat at the end. We'll be holding questions to the end, and I'm available to stay as late as needed to answer everything. So as we get better about recognizing that autism presents in different ways, and as diagnosis is made more accessible to low-income and other marginalized communities, the frequency of diagnosed autism has increased substantially in recent years. It's now estimated by a recent report from the CDC as high as roughly 1 in 44, which is more common than redheads. But training has lagged significantly, with this study that I list there from the UK, finding that almost 40% of the doctors they polled have never received any formal training in autism. And that study went on to report that this lack of training creates significant barriers to effective care. It also doesn't help that much of the older research and resulting trainings relied on a limited perspective of non-autistic professionals and family members of autistics, making what are really more educated guesses about why they think autistics think and act the way we do, rather than learning directly from autistics about how our brains and bodies work. The good news is that by the end of this hour, you're going to have a better understanding of autism than most healthcare professionals, and quite possibly even quite a few specialists, because we're going to be sharing firsthand experience, both mine and also comics, articles, blogs, and even a video short, all from different autistics to get our actual perspective and advice on providing best care. So who am I? I'm an autistic from a family of autistics. I was diagnosed originally with Asperger's syndrome in the first year. It was included in the Diagnostic and Statistical Manual, the DSM, which is the American Psychiatric Association's diagnostic manual. And that was version 4. And I got my diagnosis in 1994. After my brother, who was a non-speaking autistic, and my cousin, a semi-speaking autistic, were both diagnosed with autism. And a large percentage then of my siblings and cousins and I all received the same diagnostics of Asperger's. In 2013, both diagnoses, along with several others, were moved into the DSM-5 under the single autism spectrum disorder, which we'll get into a little bit more later about what that spectrum term means. Also, I note that I call myself autistic rather than a person with autism. This is something that varies amongst the disability community depending on the condition and their preferences. You likely have been told to be careful with making a person's medical condition a part of their identity. We don't want to say, a depressed person, we say a person with depression. And for many conditions or differences, that is the preferred option by those people. But most autistic folks say that autism is so deeply linked to our ways of thinking and interacting with the world that we cannot and should not be separated from it. We also don't consider it a bad thing that we need to be separated from. I don't call myself a person with bisexualness. Being queer is an inherent part of me. Likewise, there's no part or version of me that is not autistic, and nor should we need euphemisms to avoid talking about disability and difference. That being said, different people have very different perspectives on this, so when in doubt, think pronouns. Use what the person has made it clear they are comfortable with. I'm cramming a whole masterclass into this hour, so I'm only able to lightly touch on some of these topics we're going to be discussing, but I'm also a podcaster in addition to several of my other activities, and I actually have an entire episode talking about autistic preferences in language, including research into the actual impact some of these language differences have on our perception of people with different disabilities based on how we refer to them. And I also go into why some of these things are debates in various communities. So if you're interested in some of this topic or other topics I'm going to be touching on and seeing more of the research and the citations, as well as hearing other autistics in interviews sharing their perspectives, check me out. I'm on most podcasting platforms as Actually Autistic Educator. Apple, Google, Spotify, and whatnot. I'm also on Twitter and Facebook. And if you prefer reading, all episodes have written transcripts and most can stand alone on different topics. And at the end of each transcript, I have all of the citations I use for various articles. So who am I as myself, as Jean Clifton? I have over a decade of teaching experience of middle school, high school, and at university. My degree and license is as an English teacher. I hold dual masters in English and teaching English, though now I do a lot of work tied more to special education and neurodiversity. And while I learned a lot in my teacher training, I was very concerned that the program as written included zero explicit training for working with autistics. It's definitely not just healthcare that has this issue. We didn't even cover other common neurological differences like ADHD. A lot of what I now put into practice, both with my own students in this podcast and trainings such as this, are things that I had to glean myself from my own experiences, from firsthand accounts of blogs and social media of what worked for them. A lot of searching on PubMed to learn the biology of it. I am a humanities person, but thank goodness for my AP biology teacher in high school teaching me the basics. And there's also a lot of trial and error as I worked with students and we figured out together what things worked and what didn't. But if you had an idea in your head about what autism looked like when you were told about this panel, I may look different than what you would think. I'm a woman. I have advanced degrees. I have friends, a wonderful fiance, and a lot of hobbies. And as pretty obvious in how I've been interacting so far, I do something called masking, where I put on a mask of facial features and varied intonation to pass as non-autistic, because I find people are more willing to listen to me when I put these things into practice. But that's not to say that I don't run into serious struggles and barriers because of the ways my brain is wired differently from non-autistics and the ways our world isn't set up to be accessible for people who are different. As I mentioned earlier, the terms used by professionals in psychology have undergone serious changes over the last few decades. In the DSM-3 and 4, we didn't have the word spectrum, and instead it was split into a variety of categories based mostly on how different you seemed from non-autistics and what those differences were. But in 2013, it was recognized that these categories were very arbitrary, and which one you were put into often heavily depended on the preconceived ideas of the therapist prescribing, rather than being distinct actual subcategories. In general, most autistics support this single broad category, For more info and other sources on this, check my episode, The Problems with Functioning Labels. Almost everyone at this point is familiar with the general traits used both by the DSM for autism diagnosis and how they're often seen in movies and TV shows and such. The DSM requires persistent deficits in social communication and social interaction across multiple contexts, and restricted repetitive patterns of behavior, interests, or activities. So in practice, usually the expectation of autism is a white male child who doesn't make much eye contact, either is non-speaking or speaks in weird ways, and is obsessed with trains. Which, to be fair, that is how it can present sometimes. It actually describes my younger brother very well, but that's not the limits of it. That's the stereotype. New research being done by academics like Dr. Damian Milton and Dr. Gemma Williams is finding that many of the old assumptions about autism and also about autistic deficits in communication are actually inaccurate. And it's more that autistic communication defaults are different from non-autistic communication. It's like trying to speak French when the other's speaking Spanish. There might be a bunch of false cognates, but it's not going to come across perfectly. They're also finding that non-autistics are just as bad at accurately reading and understanding autistic communication. For more about this, do a search for the double empathy problem. There's a lot of really interesting research being published on it. We're also realizing there was a lot of bias in older research that has severely negatively impacted autistics of color and other marginalized autistics. As more research is done and published, and as some of the older research on autism that was considered the gold standard and used in creating textbooks and DSM definitions and even societal ideas about autism and gender deficits and empathy, have now failed to be replicated after multiple attempts. I'm sure you all as science people are aware of the issues that replication failure can cause to a field. So because of all of this, this changing definition of autism towards a single spectrum has been incredibly helpful, and it can make it easier for us as professionals to understand the wide array of people who are autistics, both the similarities that might give us some helpful information to know and how to make accommodations for, but also being aware of just how differently it can present. This change away from Asperger's as a separate condition is especially a good one for one particular reason, in that several years ago, it was discovered the man Asperger syndrome was named for, Hans Asperger, actively contributed to the Nazi eugenics program and intentionally referred the profoundly disabled or autistic children to a child euthanasia clinic. Understandably, this has caused some changes in how people view that term. It's also incredibly important to remember as medical professionals that the eugenics of the disabled have a long history, not only in Hitler's Germany, but also in the US, and are present even today. This influences many of the autistic community's concerns around using language like severe and profound autism. I highly recommend reading this short article, Avoiding Genetic Genocide, Understanding Good Intentions and Eugenics in the Complex Dialogue Between the Medical and Disability Communities, shown on the slide, and it will be in the links at the end. I also did a podcast episode on the Spectrum 10K controversy and the history of eugenics and how that impacts the autistic community. Given all of this, the term Asperger's, while still used by some, has fallen heavily out of favor, but because this is only from 2017 and 2018, it's still in a lot of materials you may have seen. So something to be aware of. Some folks do still use it. A lot of people really do not and find it very offensive to have that term put on them without their consent. As autistics have been creating more media that helps all of us see the differences in the spectrum, we've, as a group, mostly moved away from that, but you do find people who still use it for themselves. More about this spectrum concept. I know I'm giving a lot of homework. This dies down a little bit as we go. I'm also going to be linking and highly recommend taking a read of this short comic created by UK artist and illustrator Rebecca Burgess. It breaks down a lot of misunderstandings about that term spectrum. It takes us through autistic Archie and his struggles with folks thinking that the spectrum runs from low to high, from mildly autistic to severely autistic, all as a single dial. Unfortunately, this is how most non-autistics think about autism. And the assumptions made harm people put into both categories, with folks who are labeled low functioning being denied agency, treated as a child, not allowed to pursue education because of their support needs around speaking or moving, while those labeled high functioning are denied supports and expected to tolerate extreme discomfort, when in reality, autism can include an array of differences and struggles, even if they are less visible. Sensory issues, body control, and language use, these are all individual dials that can vary dramatically in a person that you're working with, as opposed to being a single line where you either have all of them or none of them, and you can have a lot of variations in the support needs that they then require. Because the spectrum can cover so many different variations, different autistics and potentially their families will have different accommodations that would be very helpful for you to put into practice, if possible, when you're providing care. The biggest thing that likely will come up is sensory differences. A huge source of frustration for many autistics is these sensory issues. Our brains interpret sensory information in unexpected ways and often in extremes. We can be hypersensitive, unable to tune out the buzzing of fluorescent lights that other people don't even hear at all, ever. Comfortable light levels to others can be blinding, and mild smells of cleaners or even air fresheners may be overpowering or smell very different or wrong. Most perfume smells like rubbing alcohol to me. We can also be hyposensitive, craving loud or bright things, or many people have a mix of both, where you'll use like loud music or other loud noises that you create to try to tune out the other sensations that are overpowering you and making you uncomfortable. Enough wrong sensory input can easily cause meltdowns and shutdowns. But it's really important to highlight that these aren't tantrums. If a person is struggling with this isn't something that they have control over. Personally, my worst trigger is unexpected light touches. My brain just straight up cannot identify what's going on, and it crashes out. So if someone tries to tickle me, and I tell everyone, do not do this, it will be bad, but sometimes people take that as a challenge. Bad idea. I will literally black out, and I often come to a little while later having kneed someone in the groin or bloody nose, which again is why bodily consent is important. It's like your control over your body stops and it runs on autopilot, no matter what you want. It can also shut down your ability to talk, even if you normally are able to speak. Your mouth and your tongue just don't do the things you want them to do. This can be triggered by other things, not just sensory overload, but sensory overload is an incredibly common trigger especially in medical environments and situations, and also especially for children who aren't given the agency to control their environment. I'm able to walk off to the bathroom, put in headphones, put on sunglasses. A child doesn't have those elements of agency given to them, and they're more prone to then having struggles accordingly. The best way to reduce this and overall stress, even if it's not causing melting down, if you start getting oversensoried, it can often decrease your mental acuity. So it can make it harder for autistics to think straight, is to provide options for self-selecting sensory input. So, for example, would it be possible for an autistic patient to wait in their car until you're almost ready to see them, where they can control the light, sound levels, and what is around them, as opposed to having to spend 45 minutes in a loud, crowded waiting room under bright lights? Is there a separate room that they could wait in away from other people? Can the lights be turned down, or can you make it clear that you won't judge someone or feel offended if they wear sunglasses indoors? The number of people who apparently take it as a personal affront if you wear sunglasses is concerningly high, and an autistic person just never knows if they're suddenly going to have to deal with someone deciding that they were rude when they were just trying to avoid sensory overload. It's really important to remember the amount of trauma autistics have due to living in a world that often causes very real pain, but decides that looking weird is a huge offense and something that deserves to be punished. When in doubt, ask the patient or the parent or caregiver what things could be done to reduce stress. They might not need a lot. Again, some autistics actually have other areas where their autism is more present and not as strong sensory issues, but sensory issues is a super common one that could really benefit from accommodations. The second most common issue that may pop up is language skills and the fact that autistics often communicate differently, as I briefly touched on earlier. We'll go more into autistic preferences for explicit language in a bit, but I also want to highlight that many autistics are either non-speaking or semi-speaking, but this doesn't automatically mean that they aren't able to be involved in their own care. A lot of people assume that if an autistic is not able to speak verbally, then that means they must have a serious intellectual disability and they are incapable of consenting or managing their own care, which is just not the case. Many autistics who are non-speakers have later in life been given access to what's called AAC, which is augmentative and alternative communication devices. Sometimes this can be as low-tech as writing on a dry erase board, as common as texting, or more complex apps. But these autistics have later recounted perfectly, word for word, some of the many offensive things that adults said about them, being a burden, being a curse, assuming that they didn't understand. Some autistics may have an intellectual disability, but this is a separate thing and can exist with or without struggles with body control, which is dyspraxia or apraxia. An autistic may require a wheelchair or an aid as an adult, but that's not an automatic sign that they have an intellectual disability or cannot be involved in their care. Regardless of their ability to speak verbally or aids or other supports and assistance they need, it's always best to start from assuming competence. You can always scale back from there, but if you start by making it clear you're not considering them capable of being involved and consenting in their own care, it's really hard to come back from that. I actually I have a variety of joint conditions, and I frequently use a wheelchair or crutches or cane. And the number of people who, just because I use a wheelchair, make the assumption that I must have an aid, or who lean down and start speaking to me, you know, are you lost? No, no, I'm fine. I'm in a museum taking myself around, but a lot of people are very certain that all of these are that single dial and automatically assume incapability. Always start by assuming competence. Next, I'm gonna share a short video from Communication First. This is a self-advocacy group for non-speakers. It's a short video, like 3 minutes. I highly recommend following Communication First on social media. They provide a lot of free information and trainings for supporting non-speakers from any cause, stroke, cerebral palsy, including autism. And this was specifically made by non-speaking autistics. Sorry, swapping between views takes an extra moment. All right, so we've talked about how there's a lot of different things that autism can present as. So since some people may look mostly indistinguishable from non-autistics, it's also important to know that not everyone, it will always be super clear. And also, autism is still likely chronically underdiagnosed, especially in marginalized communities. But autistics may seem less autistic, but still be facing a lot of distractions and have to expend extra effort, which can increase misunderstandings. And many people who are able to mask are pressured away from asking questions. So something to be aware of when you're working with autistics in these clinical settings is that behavior might be a mix of either extreme. So a lot of autistics have been trained explicitly not to be a bother and not to annoy people. So they might not feel comfortable asking questions they have about medication or treatment. Some people assume that more masking means a person is less autistic, when in reality, it may be more about how they were raised. If a child is yelled at, beaten, or otherwise discouraged from seeming weird, what often happens is they withdraw. But because the underlying brain differences are still there, this causes depression, anxiety, suicidal thoughts, and other severe struggles. So if a person is being very quiet, it can help to be explicit that it's your job to explain things and you don't mind. Or alternatively, give the option for who they can call or write to or email if they have questions later. Writing this down somewhere can be especially helpful. Some autistics may present more as the stereotypes you've seen of chatty and will happily ask a lot of questions because they find this interesting or they want to be certain. It's not meant as disrespect if they're asking a lot of questions you think are obvious. Our brains often focus on different elements of sentences and can get very concerned about clarity, especially when we've missed things before in conversation. Another part of the masking I mentioned before is that facial features can present very differently for autistics. My autistic friend saw me a few months ago at an event and grabbed me and asked if I was okay because they go, "You were blinking extra and your chest is flushed, and we both know that that means you're stressed." While my autistic friends just saw the smile I was keeping on and assumed I was fine. Some autistics have been trained to make certain facial features, and so even while in pain or upset, they might still be smiling. So words can often be much more helpful in ascertaining what they are actually feeling. Likewise, many who mask, if they get sufficiently stressed, suddenly stop making facial features or adding emotive sounds entirely, which other folks can interpret as not caring or not being stressed at all, when in reality, it's often a sign of severe stress. If I drop this affect that I'm using and start talking just like this, not moving a lot and keeping a steady intonation, that's a very bad sign. That means I'm in extreme pain or stress or discomfort to the point where my brain has chop it off all of the extraneous work I'm doing to try to present in ways that people will listen to me. I know this is very complicated, so consider checking out either my episode on autistic communication and masking, or just do a search for autism and masking for blogs or videos by autistics to get some examples of how broadly this can present, because it's incredibly important to not rely too much on these nonverbal cues that you often have been told to use with other patients in evaluating people and their comfort. Our eye contact, facial features, and intonation just can skew so widely compared to non-autistics. So relying on the practicalities of answers about what we can and cannot do without modification can be a lot more helpful. Following up on this, here's some complications to either diagnosis or treatment. I know we have a broad collection of careers, future careers that are being represented here. The medical environment is already pretty stressful. It's outside of our routine. We have no idea how much the doctor understands about us. I literally had a doctor last month who is a specialist in genetics and has written about autism tell me he didn't think I could be actually autistic because I was literate, which, yeah, lots of issues. So the autistic person who is already trying to figure out how to advocate for themselves as a patient, it's going to be a huge challenge to try to figure out what magic words will work and be understood. I was misdiagnosed for 6 months and did permanent damage to my spine because I was stressed and had that flat affect and didn't seem enough distressed. And I'm also very literal. Most autistics, we really can be. And so the pain scale of worst pain you can imagine at 10, for me was very different from others apparently, as I imagined horrific, brutal torture, when really they meant more like the worst pain you've personally experienced. Because I gave very different numbers on the pain scales, it caused a lot of complications. Autistics are more often much more direct in how we like to communicate. We don't do as much subterfuge or insinuation, and we also do a lot less exaggeration. We tend to be very explicit. So if you ask, is the pain manageable? We don't always translate to, are you able to do most of your usual things? What we might take it, and are very likely to take it as, well, I'm in constant agony and unable to even pay attention to my favorite movies, but I managed to get myself here. I haven't crashed completely. So yeah, I should say it's manageable right now in that I am managing it. I knew a friend who shared the pain was so bad from her chronic condition that she repeatedly considered suicide. But the doctor asked if she was managing her pain levels, and she said yes, on the grounds that, well, she hadn't actually acted on it yet. So, by that definition, she was managing it. Some things that can help are being more explicit in your language, asking what they can or cannot do, and what changes have been needed from their normal routine. Yeah, I can get around my house, but if it's because I'm borrowing my aunt's wheelchair because I can't walk, that's very different from I can walk short distances without pain, but it might not occur to an autistic to have to give that extra information. Encouraging patients to bring notes of questions ahead of time, or having them write out a timeline and specifics of what they can and cannot do can make things a lot easier. I really can't say be explicit enough. After my back surgery, I was told 1 week after to, quote, walk as much as you possibly can. And they said it would speed healing. So I took it to heart. I walked until I absolutely couldn't and caused so much inflammation, I woke up paralyzed from the waist down and in severe pain and had to go back to the hospital. It turns out what they had meant was walk until you feel mild discomfort. But they assumed that that's how I would interpret the statement, walk as much as you can. Now I know to always ask very clear and explicitly what they mean by these things. When I do PT, I say, when you say as much as I can, do you mean several times a day, until a mild pain, until light aching? And I get those specifics because my brain is often going to default to very different from other people's. Some other issues that can cause extra complications are sensory pain. Many autistics have pain responses to sensory overload that can be pretty severe. Hyperacusis can mean that a loud noise can make it actually feel like something stabbed you in the eardrum, and it can last for hours. But non-autistic parents and teachers often assume an autistic child is exaggerating and tell them they just need to deal with it. The sound's gone, stop being annoying. Many autistics, therefore, have a hard time recognizing what is and is not normal pain. Throw in that our sensory perception issues can make it challenging to identify exactly what kind of discomfort we are in. And it's not surprising that many autistics, including both my sibling and my cousin, were found to have walked on broken bones for weeks because it hurt less than the blinding lights indoors. And for my sibling, the nurse asked them, well, can you walk? Well, the answer was technically yes. I highly recommend, and I'm going to again be linking this at the end, checking out Autistic Science Person's Autistic Sensory Pain and the Medical Consequences. It's a great short read and has a lot of useful information on this. In general, you all probably would really enjoy Autistic Science Person. They have a lot of fun stuff about autism, but looking at it from a scientist's perspective as an autistic person. Another thing that can complicate things is inaccessible care. How accessible is your workplace for non-speakers, people who need mobility aids? Again, dyspraxia and apraxia can mean that an autistic might struggle with control over their own body movements and have to rely on some of these things. What assumptions are made about speaking and capability by the people who work there? Um, I love all of the different MyChart apps for communicating with doctors. It's been great. I love being able to read my notes after to make sure I remembered things correctly. But I found out recently my office admitted that if they're busy, they ignore appointment requests made on the app because they assume if it's important, then you'll call. This is hellish for an autistic because especially when stressed, I never quite know what the socially appropriate line is between helpful follow-ups versus I'm being annoying. But it's completely inaccessible to non-speakers who think that they've just put in the official appointment request and then never hear back. Um, I also know autistic non-speakers who are in graduate school who are quite brilliant, but have been told, one of my friends, I think 25 or 26, that the only way their doctor will see them is if they have a parent come in with them, because the doctor's office is not willing to meet with non-speakers on their own, even when the device is the same sort used by Stephen Hawking and requires nothing but listening on their side. The assumption is anyone who needs that type of support has to have a carer. Because of all of these different issues, many autistics become so overwhelmed with this stress and accessibility problems that they avoid medical treatment and medical care entirely because of these bad experiences, which is incredibly concerning as autistics are highly likely to have other medical conditions that require support and treatment. The exact etiology of autism, what causes it, is not exactly known, but many researchers have reported higher rates of autoimmune conditions in autistics and their family members, which explains many of some of the various associated conditions. And there's also a variety of other conditions that can be more common in autistics, but the reasons and direction of cause and effect are not entirely understood. Also, disclaimer, these are some of the more said issues that are referenced, but many studies have found conflicting results on frequency. So if you're curious, just search PubMed for autism and any of these for more information. Allergies and autoimmune conditions and epilepsy and seizures are both pretty well documented to certain degrees and very helpful to be aware of. Though while seizures are more common, there seems to be debates as to why. Autistic communities for years have found a much higher likelihood of us having things like vasovagal syncope and circulation problems, but it's mostly been ignored until very recently. There was a great article in December actually looking at autism and autonomic conditions that found they were actually heavily overrepresented in autistics. So it's also good to be aware if you're interested in research. It's not uncommon for autistic online communities to find some of these trends and comorbidities before they show up in the literature. Insomnia and gastrointestinal disorders are also classics, but there is a debate over if these are secondary symptoms caused by something autistics do, or if they're inherent to autism, or if they're just likely to also co-occur. But an interesting note here is one theory about the GI issues ties to that autoimmune issues mentioned above, because they can often be linked. And many of the fad autism diets you may have seen referenced are thought by some folks to work for some autistics because of our increased likelihood of having undiagnosed, gluten, lactose, or other sensitivities. A lot of us have very weird allergies. It took 2 years for them to figure out my brother had issues with white rice, of all things. My other sibling becomes violently ill from raspberries. Your sensory overload and resulting meltdowns can decrease if you don't constantly get overstimulated by gas, pain, heartburn, diarrhea, and such. Most of the symptoms people associate with autism are actually signs of autistic stress. So reducing stress reduces what people see as autistic behaviors. So being able to assist in those gastrointestinal issues can often help people live a better quality of life, though it doesn't actually change if you're autistic or not, just to be clear. A more interesting one that's recent is joint hypermobility. This is another one that was noticed first by autistic online communities years ago and only recently documented to academia in like the past year or two. But multiple articles since then have since confirmed this link, with a highly disproportionate percentage of autistics getting diagnoses of Ehlers-Danlos syndrome or generalized joint hypermobility, which means many autistics are dealing with severe joint pain and mobility struggles later in life and can take years to be diagnosed correctly because the assumption is that those are rare conditions and very unlikely to occur. Continuing on, it came as a huge shock a few years ago when it was discovered that approximately 20% of women in treatment for anorexia meet criteria for an autism diagnosis. This is despite the fact that autism is estimated to only occur in between 0.5 to 1% of women by most studies. The disclaimer here and side note, there's a huge issue of gender bias in autism research and autistic criteria. It's similar to how we've recently realized that heart attacks can present differently in women, but because men are assumed to be the biological default, no one noticed, and a lot of women misdiagnosis accordingly. It's highly likely that there's some similarities going on with autism. Check out my episode Rejecting the Blue, talking about gender and racial biases in autism research, or just do a search for autism and gender biases, looking at what autistics are writing about it. Even still, with that disclaimer, jumping from even 1 or 2%, if it could be higher, to 20% is huge. Those sensory issues that I mentioned before mean autistics are very likely to have strong, uncontrollable reactions to certain food textures. This can even include vomiting. Likewise, those GI issues can mean that our bodies have decided when stressed, it's just a bad idea to eat. The very idea or smell of food can cause severe nausea. And sometimes only very, very limited foods seem remotely palatable. So if you are going to be working with anyone regarding eating disorders, there is a lot of research on this that's come out in the last 2 years, but please also look at autistic created explanations of why we are this way. I have an episode on autism and food and eating struggles because the autistic perspective is it's often entirely unrelated to body image, and so the standard treatments for anorexia often don't work or can even make things worse. ADHD is a more commonly known comorbidity. Again, it's unclear if it's the exact same thing when it co-presents with autism, if both just cause similar issues with dopamine and other neurotransmitters. That's all slightly iffy. But in practice, many autistics also present with ADHD and may benefit from similar medication and other treatments if they also show the symptoms. Um, Likewise, something more interesting though is Tourette syndrome. This is lesser known, but while tics and vocal stimming can be common in autistics in general, there is also a huge overlap between Tourette's and both autism and ADHD. Again, it's unclear for the reasons, but it can be helpful to be aware of because, especially for these marginalized autistics, being less likely to be caught with a traditional autism diagnosis, it may be helpful to be aware that some of these things may be, higher likelihood of being autistic. Depression and anxiety are also both commonly seen, but interestingly so, more so in autistics who do not have intellectual disabilities and are in mainstream society, which implies that these may actually be caused by trauma from ableism that these people experience, rather than being something inherent to, the neurochemistry of autism. Again, the exact cause is unclear, but multiple studies have found that the pressure to mask or mimic non-autistics to avoid punishments or bullying also causes severe negative mental health struggles. Nothing is going to make an autistic be less autistic. Our brains are wired the way they are. And so-called therapies with this as the stated goal are now being found to have numerous downsides in increasing stress and negative mental states. So before recommending any treatments, please just do a quick search about what autistics say the impact has been of some of these things and take a look at some of the newer studies regarding autistic masking and mental health. If you're in a hospital or other long-term care situation, this can be a huge challenge for autistics. So insomnia, struggling to fall asleep or go back to sleep, if blood draws or other checks don't have to be done overnight, it can be easier to hold off till morning. Many may also be more nocturnal and not being up for eating breakfast at 8 a.m. Likewise with the food, we touched on it before. If it's possible to be open or even recommend alternatives. Texture especially can cause a serious issue. A lot of us can't eat when stressed, as I said, so being open to them eating more at night when things are quieter, any flexibility can be helpful. Sensory overload, beeping and other high-pitched noises can be murder. So, if you're in a longer situation, many autistics' brains can't filter out that background noise. And the beeping can be a big source of stress. So headphones, doors shut, private rooms, very helpful. Likewise with touching, like I mentioned before, unexpected touching can cause a panic response. So make sure they're aware, check firm versus soft. And routine is very, very important. Autistics routine is now entirely gone if they're in a hospital for longer term. So making it clear what will be happening and warning of any changes in advance can make things a lot helpful. Finally, we're close to the end. It's frustrating that the Autism Speaks is the group associated most commonly with autism, but has a very concerning history, and a lot of autistics consider it a hate group. Before doing something with them, do an internet search for Autism Speaks in Controversy, and you'll find all of the different reasons many autistics react very negatively to them. In general, check for organizations led by the people they claim to help. Good rule for everything. The next slide will be autistic-led organizations. Likewise, colors, blue versus red. Blue was picked because autism is associated with boys. For a while, it was called extreme male brain theory. There's a lot of sexism, very annoying. And the colors associated with Autism Speaks. So many autistics actually boycott lighted up blue and other blue things. Red is the color used by many, as well as gold. AU for autistic is the symbol of gold on the periodic table. Puzzle piece logo, originally it was actually a child crying with it and a puzzle because autism was seen as a mystery that destroyed families. A lot of weird and grossness to it. Many autistics find the puzzle piece offensive. The most common autistic created option is the rainbow infinity symbol to support the spectrum of differences that exists. And that's the infinity symbol on the left there. The other one is my personal logo because a lot of autistics take some of these elements and colors and symbols and combine them for their own work. Oh, it's also, it's not the actual reason that the rainbow's involved, but this didn't come up before. Autistics are dramatically more likely to be queer and trans or non-binary. So definitely don't assume they're straight and cis, and never assume that their gender identity isn't valid or is less valid because they're autistic. Finally, here's some recommended resources that all have websites and social media that you can check out. And it's 1:59, so I will just leave those up on the screen and ask if folks have any questions.
Thank you so much. Yeah, I think a lot of us are going into class right now. Really appreciate you for your time. I guess the one question I have, and you can leave this on the recording if you want, is why did we call this event Autism Acceptance versus Autism Awareness?
Thank you. I realized that I had added a couple of things as I went, and I had to trim down some of my work in the last 2 slides. Yes, Autism Awareness was the original campaign created by Autism Speaks and other groups that were not autistic-led. Autistic Acceptance is what autistics have been asking for because people don't need to be aware that autism exists. We know autism exists, pretty much everyone does. What we need is acceptance that autistics be allowed to be autistic and not treated poorly or differently or shamed for it or told that they need to act in ways other than their autistic self in order to exist in the world. Thank you for that. I added a little too much extemporaneous stuff and realized I was running late and had to trim on the fly, but that's a very good part to include.
Again, thank you so much. If there's any RFU students who are interested, Dr. Dumais actually has a special section about autism in her mental health elective, if anyone's interested in that. But anyways, thank you so much, Gian.
Thank you.